Could I just extend my personal gratitude for two outstanding presentations. Thank you very much. We come now to the 2013 Sir George Pickering Lecture. And this year, it's a great personal pleasure to invite Dr. John Hall from Jackson, Mississippi, to address us. By a brief way of background, he persuaded his wife some years ago to go to Mississippi, saying that he would only be there for a couple of years, but he wanted to work with Arthur Guyton. Subsequently, he became the Arthur Guyton Professor and Chair of Physiology at the same institute and Director of the Mississippi Center for Obesity Research. And he's been there ever since, garnering a reputation for outstanding cardiovascular physiology. His major research interests focus on cardiovascular and renal physiology. He is dedicated to his subjects. He has published more than 500 papers, and he has written 18 textbooks, some of which are seminal works worldwide. He has time for his family and his 3 children and the grandchildren, although his wife tells me that when his cardiology son comes to the table for dinner, they lapse into physiology discussions, excluding the rest of the family, so there's no peace at home either. He is, by all accounts, one of the foremost authorities in his field and has been for some considerable time. He has been honored by a variety of institutes and societies, but the omission, of course, is our Pickering Lecture. And so we're going to put that right today. And John, I'd like you to present your lecture. Thank you.
Well, thank you very much, Tony. It's a great honor and a great privilege to present this lecture today in honor of Sir George Pickering. I did not have the pleasure of knowing Professor Pickering, but I did have the pleasure of reading many of his works in the literature. His textbook is a textbook which is really entertaining as well as informative for those of you who have not had a chance to read it. Sir George Pickering was certainly well known for his contributions in many areas of medicine, experimental medicine, as well as clinical treatment of patients, but he was well known for his work, for example, in the development of assays for renin, in understanding the renin-angiotensin system. He, along with Professor Peart, sequenced or determined the amino acid sequence for angiotensin II and purified angiotensin II, along with many other important contributions. But perhaps one of his most important things that he's been remembered for is his quantitative approach to medicine as well as to hypertension. And as he pointed out, science begins by being descriptive, but it develops by being quantitative. And so I think that this is one of the major contributions that I'm going to talk a little bit about today when we talk about obesity and understanding the quantitative importance of obesity as a cause of high blood pressure. Now, when I began my work in this area of hypertension, the dominant theory was Irving Page's Mosaic theory of hypertension. And basically it said that hypertension is complex, it involves many different factors, but there was no real hierarchy among the different factors and no quantitative importance assigned to any of these factors. And any attempts to be quantitative were really relegated to simple statements such as blood pressure is equal to cardiac output times total peripheral resistance. About this same time, about in the early 1970s, another group was developing another approach to hypertension, and this was the Guyton version of the Mosaic theory of hypertension, in which he began to develop the first comprehensive systems analysis of blood pressure regulation and the various factors that might lead to hypertension. As Tony said, I was at Michigan at the time. I was very interested in mathematical modeling and in physiology, and I did convince my wife to go to Mississippi, to this godforsaken place that many people, at least in the north, did not want to go to, but I did stay 39 years, and if any of you have a chance to visit, I would say that it's not such a bad place. But please feel free to come and visit, and we'd love to welcome you to Mississippi. There is a sign as you go into Mississippi, as a matter of fact, that says "Welcome to Mississippi." Well, during the time that I was in Mississippi, I had the great pleasure of working with Dr. Arthur Guyton. It was a very fortunate experience for me. I worked with him until 1989 when he retired and I became chair of physiology. But my first task when I got there was to try to develop in more detail the quantitative analysis of the kidney and its role in long-term blood pressure regulation, and also to develop experimental approaches to test the various concepts that were being proposed. And so we looked at the control of renal hemodynamics, we looked at the renin-angiotensin system, and I spent many of the early years working on the renin-angiotensin system and its role in blood pressure regulation, and looking at tubular function. And as you can see, the mathematical modeling began to expand, tremendously expanded, mainly under the influence of Dr. Guyton as well as Dr. Tom Coleman. This shows the current mathematical model, and you can look at it online. It's about 8,000 equations now, or 8,000 variables, which has led us to understand, I think, better and to put into perspective the quantitative aspects of cardiovascular regulation. But one of the simple concepts that arose from this modeling was the concept that all forms of hypertension, whether they're salt-sensitive or salt-insensitive forms of hypertension, all forms of hypertension are associated with some impairment of kidney function as manifest by an altered pressure-natriuresis relationship. Pressure-natriuresis simply refers to the effect of increased blood pressure to raise the salt and water excretion by the kidneys. And it's obvious that there must be a shift of the pressure-natriuresis in hypertension so that sodium balance can be maintained at the elevated arterial blood pressure. But the early studies that we did focused on first proving whether or not, or testing whether or not, the pressure-natriuresis mechanism was critical in long-term blood pressure regulation. And then secondly, looking at the various factors that regulate pressure-natriuresis, both intrarenal factors and neurohumoral factors, dietary factors, and so forth. We focused a lot of our attention on what we would now call secondary forms of hypertension, those caused by renal artery stenosis, angiotensin infusion, aldosterone infusion. But we always came back to the question of what is the key factor that causes impairment of pressure-natriuresis in common forms of hypertension in humans, primarily primary hypertension. So one of the things that we learned early on when interacting with our clinicians was that most hypertensive patients, at least in Mississippi, and I think perhaps this is true in the UK as well, most hypertensive patients are either overweight or obese. So we can see the increase in obesity during the past 30 or so years in the US. Now almost 2/3 of the adult population is overweight, and 1/3 of the population is obese. And if you look at the incidence of obesity in children, you can see that it's increased in parallel. In fact, the most recent data suggests that 20% of 4-year-olds that are preschoolers, 20% are now either overweight or obese in the United States. This is, even our pets are overweight in the US. 40% of dogs and cats that come to clinic are overweight according to the National Academy of Sciences, and for those who like to argue about genetics versus environment, I think perhaps this has some implications here. But it's not just a US problem, it's a worldwide problem. In fact, if we look at the top 30 countries in terms of the prevalence of obesity, the US is only number 19. You can see that in some countries, the prevalence rates reach 60 to 70%, at least in females in certain countries. So it's a worldwide problem, and as we're going to hear, I'm sure, later on today, it's also a problem in the UK. In fact, the UK, turns out, has the highest incidence of obesity in the European Union. Now, associated with obesity is a cascade of metabolic and cardiovascular disorders, which is often referred to as the metabolic syndrome. However, it's clear that obesity is the prime driving force for all of these disorders, including hypertension, the main area that I'm going to focus on today. The importance of obesity as a cause of hypertension has, I think, been adequately demonstrated, first from animal studies showing that weight gain raises blood pressure, second from clinical studies showing that weight loss lowers blood pressure in most hypertensive patients, and then finally from population studies such as the Framingham Heart Study and many others, which have shown that excess weight gain accounts for 65 to 75% of the risk for hypertension. Now, Professor Pickering made an important point that hypertension is not a qualitative trait, but it's a quantitative trait, and the same is true for obesity. Obesity is a quantitative trait, and what we know is that obesity shifts the frequency distribution for blood pressure to higher levels so that a greater fraction of obese people are hypertensive. Now, not all obese people are hypertensive, but so there are some normotensive obese individuals. But if these individuals actually lose weight, and there are many studies showing that if they lose weight, the blood pressure falls to a lower level, indicating the impact of obesity on blood pressure, regardless of whether you happen to fall into the hypertensive range or not. So today I'm going to talk a little bit about some animal studies as well as some clinical studies, but mostly focusing on animal studies because I am a physiologist. But in doing that, I'm a little bit mindful of the admonition of Sir George, who said, and I'll paraphrase here, he basically said that extrapolating results from animal studies to understanding sick patients is a bit of nonsense. So I'm going to give you a bit of nonsense today, but hopefully I'll try to weave this in with some of the clinical work that has also been done in this field. Now, this just summarizes some of the data that we've obtained in various animal studies. We've shown, for example, using genetic as well as dietary models, that obesity leads to hypertension. But one of the things that we've seen is that animals fed a high-fat diet, particularly dogs and rabbits, and less so rodents. But these animals demonstrate many of the characteristics that we see in obese humans. They have high blood pressure, increased heart rate, increased cardiac output, mild activation of the sympathetic and renin-angiotensin system, and I emphasize mild activation. I'll come back to that point later. Sodium retention, which is due primarily to an increase in the tubular reabsorption of sodium, increases in GFR or hyperfiltration in the kidney, and then a host of metabolic abnormalities, including insulin resistance and hyperinsulinemia. And from these studies, we have suggested and postulated that there are three key mechanisms that link obesity with increased blood pressure. And the first of these is physical compression of the kidneys. Physical compression due to fat surrounding the kidneys, or retroperitoneal fat, and you can see here in this obese dog kidney, we see that the kidney is almost completely encapsulated with fat. And for those of you who remember the old paranephritic or renal rat model of hypertension, this is what it reminded me of when I looked at the first kidney. In fact, this is the first kidney that we took out of an obese dog. You can see that it's completely surrounded by fat. In addition, there is fat in the renal sinuses, which also seems to act as a compressive force on the kidney. And in addition to that, we saw marked changes in the extracellular matrix, an expansion of the extracellular matrix in the kidneys, particularly in the renal medulla at the early stages of obesity. These data were taken after only 6 to 8 weeks on a high-fat diet. Now, we looked at human kidneys. We looked at 180 kidneys. From autopsies, we found exactly the same changes: tremendous expansion of extracellular matrix in the renal medulla, fat surrounding the kidney and adhering to the kidney, as well as increased fat in the renal sinuses. And so we postulated that one of the factors that could link obesity, particularly visceral obesity, with hypertension is physical compression of the kidneys, which in turn would raise the tissue pressure to a level that would increase sodium reabsorption, leading to the development of increased blood pressure. We found some evidence in support of this. We did find, in fact, that the interstitial fluid hydrostatic pressure is markedly elevated. And you can see the number here, going back, you can see the number 19 millimeters of mercury. For those of you who are renal physiologists, you'll recognize that the tubular pressure, particularly in the loop of Henle, is only around 12 millimeters of mercury. And because the tubule is a very thin structure, this would completely collapse the tubule unless there were, in fact, compensatory changes taking place. So there is a very marked increase in pressure suggesting some compressive force. In addition, in human studies, this is a relatively small study of 205 patients. There was a good association between renal sinus fat and the blood pressure, as well as a number of antihypertensive medications. And then in this larger study in the Framingham group, over almost 3,000 patients, there was a good association between the renal sinus fat and the development of hypertension or the blood pressure. So there is significant data, although certainly not proof, that compression of the kidneys could be an important factor in the development of obesity-induced hypertension, particularly when there's visceral obesity. Now, this certainly is not amenable to treatment with drugs. It obviously can be treated with weight loss, and it is reversible. We've seen this in animal studies as well as in human studies. When we look at visceral fat and renal sinus fat, it is reversible with weight loss. The second mechanism, which is amenable to treatment with drugs, is activation of the renin-angiotensin-aldosterone system, and particularly mineralocorticoid receptor activation. We and many others have shown that there is a mild activation of almost every component of this system, including renin, angiotensin, aldosterone, and so forth. And I emphasize mild here. If you look at the numbers carefully, you'll see that there's only about a 10 to 20% increase in many of these variables. We see the same thing in our obese dog model, where the renin activities are slightly elevated and aldosterone is barely elevated in this study. In some studies, it's really not significantly elevated. And yet, if we block the renin-angiotensin system, either with an ACE inhibitor or an angiotensin receptor blocker, we see a rather marked reduction in blood pressure in both humans as well as in animal studies, suggesting that the renin-angiotensin system is playing an important role in the hypertension. Surprisingly, when we blocked the mineralocorticoid receptor, we also saw marked reduction in the sodium retention in this dog model of obesity. And again, this model was produced by feeding the dogs a high-fat diet over a period of 5 weeks. You can see that there is a marked retention of salt and water, expansion of the extracellular fluid volume, and that this is attenuated by mineralocorticoid receptor antagonism. The sodium retention is not related to reduction of glomerular filtration rate. In fact, just the opposite. There is an increase or hyperfiltration in the kidneys, which parallels the increase in protein excretion that we see even in this early stage of hypertension. And you can see also that this hyperfiltration is almost completely abolished by blocking the mineralocorticoid receptors. In addition, we see that about 60% of the hypertension is also attenuated by mineralocorticoid receptor antagonism. Now, this was a bit of a surprise to us when we first looked at this. In fact, the postdoctoral fellow that was working on this, I told him that we're probably not going to get a positive result here because the aldosterone levels are not elevated. In addition, when we looked at the renin activity, we're very surprised because the renin activity increases dramatically after blocking the mineralocorticoid receptor, and angiotensin levels increase dramatically. And yet, still, mineralocorticoid antagonism lowers the blood pressure in this model of obesity. So we wondered whether combined blockade might be even more effective. And in this study, the animals were placed on a high-fat diet for about 10 weeks. They were then given the ACE inhibitor lisinopril. And you can see the significant reduction in blood pressure, the expected reduction. But not shown here, there was also a decrease in plasma aldosterone concentration. In fact, the aldosterone levels decreased to values that were actually below what we measured in normal lean animals. So there is actually a decrease in aldosterone level. And yet, when we added eplerenone, or the mineralocorticoid receptor antagonist, we saw a further reduction in blood pressure, suggesting that both angiotensin and mineralocorticoid receptor activation are contributing to the maintenance as well as to the development of hypertension. But this also raised another question, and that is, why is MR blockade so effective in lowering the blood pressure if the aldosterone levels are not elevated? Is there increased sensitivity, increased ENaC expression? There is, in fact, increased ENaC expression. But we also wanted to look at the possibility that there might be something else activating the melanocortin receptor besides aldosterone. And we wanted to specifically look at the potential of cortisol activating the MR receptor. Now, you know that cortisol circulates in the blood at a concentration about 100 times greater than the concentration of aldosterone. And in fact, the MR receptor has a high affinity for cortisol. But it's protected from activation by cortisol due to the effect of 11-beta-HSD2, which is co-localized with the MR receptor. And what this enzyme does is to convert active cortisol to inactive cortisone, thereby protecting the MR receptor from activation. And you're also familiar with the syndrome of apparent mineralocorticoid excess, which is associated with a reduction in the amount of 11-beta-HSD2. So we wondered whether in obesity there might in fact be some factor reducing the 11-beta-HSD2, thereby allowing glucocorticoids to activate the MR receptor. And to make a long story short, we found that there was in fact a remarkable reduction in the 11-beta-HSD2 enzyme in the kidneys of obese dogs. And when we looked at the protein levels, there was about a 70% reduction in the 11-beta-HSD2. This would suggest, at least provide the potential, that glucocorticoids could be an important cause of the MR activation, at least a partial cause of the MR activation in obesity. Now, studies are being conducted in humans to see whether this is correct in humans. We don't have the data yet, but this does appear to be true in humans. I would say that it does not appear to be true in rodents. When we've looked at various rodent models of obesity, we do not see the downregulation of 11-beta-HSD2, and likewise, we do not see that MR blockade in rodents is effective in lowering the blood pressure as it is in dogs as well as in humans. But regardless of the precise mechanisms, I think what these observations suggest is that MR blockade might be particularly effective in obesity-induced hypertension, not only by reducing blood pressure and preventing salt and water retention, but also perhaps by increasing plasma potassium concentration. Now, this is an effect that's feared by many clinicians, particularly clinicians who are treating diabetics or clinicians who are treating patients with renal disease. But many individuals with obesity also have a reduction in plasma K. And so an increase in plasma K could be beneficial in terms of its vascular protective effects. Secondly, the reduction or prevention of hyperfiltration. And finally, the reduction in cardiac workload, which could be particularly effective or particularly important in those patients which have a tendency toward heart failure. But I think still clinical trials are needed. We have no large-scale trials looking specifically at the efficacy of MR blockade in obese hypertensive patients. The third mechanism, which also appears to be important, is activation of the sympathetic nervous system. Now, we and others have shown using a variety of techniques that the sympathetic system is activated in obese patients, particularly those with visceral obesity. We've shown in the dog model that if we block alpha and beta adrenergic receptors, that this can block about 60% of the hypertension. And we've shown in obese humans that blocking alpha beta receptors lowers blood pressure measured using ambulatory blood pressure monitoring to a greater extent than we would expect to see in lean individuals, as you can see in this slide. So it's clear that activation of the sympathetic system contributes to the development as well as to the maintenance of obesity-induced hypertension. We've also shown that this effect is due primarily to activation of the renal nerves, because if we denervate both kidneys, we see that this attenuates the hypertension as well as the sodium and water retention. And I think we heard yesterday about the efficacy of renal denervation in resistant hypertensive patients, at least in some resistant hypertensive patients. And if we look at the data carefully, you'll see that most of these patients are overweight and obese. In fact, most of the trials that have been done, the BMI is around 30 to 32 in most of these trials. So it's clear that obesity, particularly visceral obesity, increases blood pressure in part by activating the renal sympathetic nerves, which has a direct effect to increase sodium reabsorption, but also an indirect effect to activate the renin-angiotensin-aldosterone system. But it also raises the question of what is it about obesity that is leading to activation of the sympathetic nervous system. We have looked at a number of these mechanisms. I won't bore you with the details of all of these studies, many of which were negative. We've shown that there is arterial baroreceptor dysfunction. But one of the more interesting mechanisms appears to be leptin. Leptin, of course, is released by fat cells. It acts on the hypothalamus to reduce the food intake, but also to stimulate energy expenditure by activation of the sympathetic nervous system. And we wondered whether this could also be one of the mechanisms accounting for the increase in blood pressure. And so the very first experiment that we did was a rather simple study. We took some rodents, we infused them with leptin. These are normal rodents, lean animals. Infused them with leptin at a rate that raised the blood concentrations to values that we would expect to see in severe obesity. And as expected, we saw the typical anorexic effect, tremendous weight loss in a short period of time, which would normally tend to lower the blood pressure. But instead of lowering the blood pressure, this led to a slow progressive increase in blood pressure as well as an increase in heart rate. And this increase in blood pressure was completely abolished by alpha and beta adrenergic blockade, indicating that it was due to sympathetic activation. In fact, after alpha beta blockade, you can see that leptin infusion actually lowers the blood pressure as well as the heart rate. And this is due probably in part to the weight loss, but also due to stimulation of nitric oxide. We showed that if we block nitric oxide, or if we inhibit nitric oxide synthesis using L-name, that we actually got an amplified effect on the blood pressure, and not shown here, also an amplified effect on the heart rate. So what these data show is that leptin can raise the blood pressure. It doesn't say that leptin is the key factor, but it can raise the blood pressure by activating the sympathetic nervous system. In normal animals, leptin also has counterbalancing effects of reducing weight and stimulating nitric oxide formation. But in obese patients who have impaired endothelial function and impaired nitric oxide formation, we might expect to see an exaggerated effect on the arterial blood pressure. Now, I think further support for the idea that leptin could actually be causal or could contribute as a link between obesity and hypertension comes from a number of studies from our lab and others showing that animals which are leptin deficient become extremely obese. They have many of the characteristics of the metabolic syndrome, including hyperinsulinemia, elevated glucose, dyslipidemia, but instead of having high sympathetic tone and high blood pressure, they actually have low sympathetic tone and lower the normal blood pressure as measured 24 hours a day using telemetry. So this is all well and good for rodents, but again, I'm reminded of Sir George's admonition about animal studies, and I have to say that there are very few studies in humans because the deficiency of leptin is a very rare genetic cause, and you can see that those individuals, Dr. Faruqi here in Cambridge, showed that these individuals become extremely obese. They have many of the characteristics of the metabolic syndrome. They have hyperinsulinemia, dyslipidemia, but instead of having high sympathetic tone, they have actually low sympathetic tone and no indication of increased blood pressure, suggesting that in humans as well as in rodents, a functional leptin system is critical in linking obesity with sympathetic activation and increases in blood pressure. Now, we've been interested in how leptin activates the sympathetic nervous system, and one of the key pathways that we looked at was the potential effect on these neurons called POMC neurons, or pro-opio-melanocortin neurons. These are located in various regions of the brain, but primarily in the arcuate nucleus. they send projections to second-order neurons in the paraventricular nucleus, where they release alpha MSH, which then stimulates the melanocortin 3 and 4 receptors. These second-order neurons then send projections to the brainstem, particularly the nucleus of the tractus solitarius, and it's well known that these neurons contribute to the regulation of food intake. They reduce food intake when activated. So we wondered whether these neurons also might lead to an elevation in blood pressure. Could this set of neurons be important in stimulating sympathetic activity? We tested this by developing an animal model in which we specifically deleted the leptin receptor only on the POMC neurons. And we did this using Cre-Lox recombinase technology. So these animals have leptin receptors everywhere in the body except for the POMC neurons. And to our surprise, these animals were not very overweight. In fact, I have to change the textbook a bit of physiology because you can see that there's only a slight increase in body weight in these animals. And you can also see that they have a normal reduction in food intake when we infuse leptin for 7 days. So these neurons do not seem to play a critical role in mediating the effect of leptin on food intake. On the other hand, when we looked at blood pressure, we saw that these animals have a reduction in blood pressure at baseline, and they have absolutely no increase in blood pressure during chronic hyperleptinemia, indicating that leptin's effects to stimulate sympathetic activity are mediated almost entirely by activation of the POMC neurons. And we also found that this effect on the POMC neurons explains most of leptin's anti-diabetic effects. You can see that in these animals, when we infuse leptin in normal animals, we get a reduction in insulin as well as a reduction in glucose. This is due primarily to an increase in peripheral glucose utilization. And you can also see that this is completely blocked in the animals with deletion of leptin receptor only on the POMC neurons. So from these studies, we've concluded then that leptin can activate the sympathetic nervous system and raise blood pressure primarily by activating the POMC neurons, and also the anti-diabetic effects of leptin are mediated primarily by these neurons, whereas the effect on appetite appears to be mediated by non-POMC neurons located in other regions of the brain. And we've been looking at that, trying to separate out the appetite suppressing effect compared to the blood pressure effects. But this is a system which has also been looked at from various pharmaceutical companies in an attempt to develop anti-diabetic drugs. And we've shown, and others have shown, that when we block the MC3/4 receptor, as you might predict, there's a marked increase in food intake. And in fact, these drugs are now being used for treatment of cachexia in wasting syndromes, particularly cancer, heart failure patients, because you get a rather dramatic increase in food intake when you block the MR receptor. You can see that in the spontaneously hypertensive as well as the WKY rats, we have a very large increase in food intake. But instead of blood pressure going up, this doesn't seem okay. Instead of blood pressure going up, we actually have a reduction in blood pressure and a reduction in sympathetic activity, particularly in the spontaneously hypertensive rat, which has a high sympathetic tone. Conversely, if we activate the MC3/4 receptor, which was thought to be a good approach to treat obesity, because we know that activating that receptor leads to a decrease in food intake, but it also leads to an increase in sympathetic activity and an increase in blood pressure. And this shows what happens in rats, where we activate the receptor over a period of approximately 10 days. You can see an increase in blood pressure, which is due to sympathetic activation. It's completely blocked with alpha and beta blockade. Now, the same thing was shown by Steve O'Reilly's group in Cambridge, who, again, testing whether these compounds might be useful for the treatment of obesity. We had shown this many years before in rodents, but going back to Sir George Pickering's admonition, most of the pharmaceutical companies felt that perhaps this was not true in humans, so large clinical trials by 5 or 6 companies were undertaken, some at a cost of $50 to $100 million, in which the trials all proved to be negative in terms of, positive in terms of weight loss, but negative in terms of the fact that they all led to an increase in blood pressure, as was shown with this compound by Dr. O'Reilly's group, in which the blood pressure increases within 24 hours. Dr. Faruqi also showed that in individuals with MC4 mutations, that these individuals have extreme obesity. They are hyperinsulinemic, they have many metabolic abnormalities, but instead of having hypertension, they actually have a low blood pressure and low sympathetic activity. So what these data suggest, and what we would like to propose, is that the leptin-POMC melanocortin pathway is playing a key role in linking obesity with sympathetic activation and with the development of hypertension. This is an important target, or potential target, if we can separate out the effect on blood pressure from the effect on appetite, and current studies are underway. There are some encouraging results which suggest that this may be possible, but we still need to learn a lot about the physiology of this pathway. The sympathetic activation also leads, at least in part, to activation of the renin-angiotensin-aldosterone system. However, we also have shown that activation of the melanocortin receptor may be at least partially independent of aldosterone. And then finally, we have physical compression of the kidneys, which is also contributing to the development of hypertension through increases in sodium and water reabsorption. The increase in blood pressure, when combined with the various metabolic abnormalities, ultimately leads to renal injury. And once the renal injury develops, and our studies in animals show that this can occur rather rapidly, once this develops, the hypertension becomes more difficult to control, and we have a positive feedback system here with further hypertension, further renal injury, and making the hypertension more resistant to treatment and leading to, in some patients, severe renal injury. The current therapeutic approach to treatment of obesity is largely aimed at treating the risk factors, particularly hypertension, which is a critical risk factor to treat. We have many drugs that we can use to treat hypertension. I've emphasized that, at least in some studies, melanocortin receptor antagonism and blocking the renin-angiotensin system appears to be especially effective. But treating this whole cascade of disorders is difficult, it's expensive, and not successful in many individuals who are resistant to treatment. The most obvious approach would be to treat the underlying causes by reducing caloric intake or increasing physical activity. It's easier said than done. We've not been very successful, at least in the U.S., in increasing physical activity, despite the proliferation of health clubs around the country. About 75% of U.S. adults actually have insufficient physical activity to maintain good health. So we're not doing a good job in terms of physical activity. And in fact, it's well known that diet, exercise, or lifestyle modification has a high recidivism rate. Within 1 year, many studies show that about 90% of patients return to their original weight within 1 to 5 years. For those individuals who can lose weight, we know that this is effective. Many studies, the trials of hypertension prevention, many other trials have shown that even modest weight loss is effective in reducing many of the risks, including hypertension, including diabetes, including the various other risk factors, if the weight loss can be achieved. The current guidelines for treating obesity are shown here for the National Heart, Lung, and Blood Institute, and of course they recommend diet and exercise for all categories of obesity. They recommend surgery for individuals who are morbidly obese with a BMI greater than 40, or even lower with comorbidities, and we've seen in the U.S. at least a tremendous explosion of gastric bypass surgeries, many types of bariatric surgeries. However, this is not for all individuals, and we have a large number of folks here in the middle who are recommended for pharmacotherapy, who are not able to lose weight using lifestyle modification. So what about pharmacotherapy? The problem is we don't have any drugs. We only have one drug prior to 2012, which was orlistat, which is certainly has very modest effects on weight loss and has very messy side effects. Sibutramine was removed from the market in 2010 because of its increased risk for stroke and myocardial infarction. But in 2012, there were 2 drugs approved, the first 2 drugs in the U.S. in 13 years to be approved for the treatment of long-term treatment of obesity. One was lorcaserin. It's a serotonin receptor agonist. Some of you may recall the fen-phen fiasco many years ago, and this is part of the fen-phen combination, which was associated with pulmonary hypertension and valvulopathy. But in the Bloom trial, the data suggested, at least over this 1-year trial, that there was no valvulopathy or no increased incidence of valvulopathy or pulmonary hypertension. I think we still need to wait longer trials before we can say that this is really a safe drug. There was a significant reduction in weight, but it was a rather modest reduction, and it's not very encouraging for those who want to have long-term weight loss. When you lose 4 kilograms, 2 to 4 kilograms, it's not very encouraging. The second drug that was approved was Conexa or Casimia, which is a combination drug, again, of 2 old drugs, phentermine and topiramate, a sympathomimetic and an anticonvulsive drug. And again, although this was approved, the results are not so encouraging. You can see that there is a plateau with regard to the weight loss compared to the placebo. It's a fairly small weight loss, 6 to 8% at the most. Blood pressure did not increase in this study because of the low doses that were used of phentermine. But again, this is, I think, not terribly encouraging for those folks who are looking for large amounts of weight loss. There are many other drugs that are being developed. I've listed a few of the ones that are being developed. 2 of the ones that are on this chart here have already been taken off clinical trials because of important side effects. So what I would like to end with is to say that we have lots of opportunity in drug development. We have so far not developed a good drug for the treatment of obesity. And let me just summarize with a couple of take-home points. First is that excessive weight gain is the key cause of essential hypertension. We think it accounts for 65 to 75% of the risk for hypertension. The mechanisms involved appear to be multiple. At least 3 mechanisms that we've identified include physical compression of the kidneys, activation of the renin-angiotensin-aldosterone system, and particularly mineralocorticoid receptor activation, activation of the sympathetic nervous system, perhaps due to the activation of the leptin-melanocortin system. We know that sustained obesity over many years leads to target organ injury, which leads to further hypertension and making the hypertension much more difficult to control. Weight control, we think, should be the cornerstone of all primary and secondary prevention of cardiovascular disease, because even small weight loss, if it can be achieved, is effective in reducing the risk for cardiovascular disease. Diet and exercise strategies, however, we know also have a very low success rate. And depending on the unit that you're in, some report success rates of 10 to 15%, which is fabulous. Most report success rates less than 5% over a 1-year period. So short-term pharmacotherapy may be useful in some patients, but rapid gain of weight returns in those individuals as soon as they're taken off the therapy. And we know that chronic obesity is a chronic disorder, and we need long-term effective treatments for obesity. The problem that we've seen so far is that most of the treatments for obesity are centrally acting drugs. These drugs have the serious side effect typically of raising the blood pressure in patients who are already at risk for cardiovascular disease, or in the case of drugs like rimonabant, they have other central nervous system effects which lead to depression and increased suicide. So this has been a real challenge to the pharmaceutical company to develop safe drugs, and we need further research to understand the mechanisms involved in linking obesity with sympathetic activity and blood pressure regulation. I've shown here the expanding, in fact, the explosion of knowledge that we've had in the past several years. But I think Professor Pickering would say that we're at the descriptive phase rather than the quantitative phase. Most of the knowledge that we have is very descriptive. We know that these mechanisms affect appetite, they affect energy balance, but we still don't know much about the quantitative aspects of this. And again, to quote Professor Pickering, he says that ignorance and the awareness of being ignorant is the sine qua non of a productive scientist. Once he knows or thinks he knows, his usefulness is ended. By this criteria, I think perhaps I'm still a productive scientist. I'm not useless yet, so I'm going to try to convince my chancellor with this quote that there's still work to be done. So thank you very much for your attention. Let me say again, it's a great pleasure to be here to participate in this meeting. Thank you very much, Tony.
Thank you very much indeed, John. Now, as I said to you before, there is a sort of paradox here. There is a historical tradition that the Pickering lecturer is not exposed to questions, but then Steve McMahon came and we did expose him to questions. So seeing as we have 1 or 2 minutes, we can ask if there are any questions.
I would be delighted to answer questions if I can.
We have a question.
Oh, I can only congratulate you on your excellent presentation. Hilton Chaves from Brazil. Could you explain why after bariatric surgery, after 8 years without hypertension, the blood pressure can increase again? Because in diabetes patient we cannot see it, but in hypertensive patient we can.
Yeah, I think you're talking about the Swedish obesity study, which suggested that after 10 years, the blood pressure did return. Many of these patients received gastric banding, some received Roux-en-Y surgery. But there are other studies now that have looked at this over a 7-year period, and so far those studies have not shown a return of blood pressure. Now, so I would be open-minded about it yet as to whether the blood pressure really does return to normal. The Swedish obesity study was not designed as a blood pressure study to begin with, and so I think we need careful blood pressure measurements. I would like to see ambulatory blood pressure measurements in these studies. The most recent studies that have been published up to 7 years have not shown a return of blood pressure. There is a long-lasting effect to lower the blood pressure. But I think we still need to look at this more carefully using really good measures of blood pressure. This is a critical question.
John, not all obese patients go on to suffer the consequences of their obesity in terms of hypertension or diabetes or even cancer. Mm-hmm. Is there any difference if you look at the different populations? Can you pick out from the healthy obese people a phenotype?
Yeah. Well, I would say that, the clinical data, the population data, and the animal data all support the idea that visceral obesity is the real critical element there. And a lot of the studies that have been done looked at BMI only. And as we're all aware, BMI, in fact, I think, just to go back to a clinical study that we started a few years ago, we were looking at the impact of reducing body fat by large volume liposuction versus reducing body fat using gastric bypass surgery. And what we found was that reducing body fat using large volume liposuction, in fact removing as much as 20 kilos of fat off of some individuals, had no beneficial effect. In fact, we thought that perhaps this might lead to actually a storage of fat in other regions, in regions such as the liver, the heart, the kidneys. So I think what we really need to do is to look at where the fat is stored, not so much how much fat you have or how much body mass index you have, but where the fat is stored. We know that liver fat, kidney fat, cardiac fat are all tremendous risk factors for cardiovascular disease. But subcutaneous fat does not seem to be a risk factor.
Ian?
Yeah.
The leptin data is very interesting, and this dissociation between the sort of hemodynamic effect and the appetite or weight gaining effect. Why do you think you don't see that with the melanocortin modulating drugs?
Why you don't see the well, they have the same effect. But there's no resistance to the melanocortin drugs in obesity. In obese patients, there is a resistance to the appetite-suppressing effects of leptin. But there does not seem to be any resistance to activation of the MR receptor in obesity. So, again, in obese patients, treatment with MR receptor agonists is effective in reducing weight. The problem is it just raises the blood pressure. So the pharmaceutical companies are really interested in this approach. They're trying to get around the blood pressure effects. So there is some promising approaches to this. I'm not at liberty to talk too much about them, but there is some promising data that suggests that this is possible to get around the effect.
Professor Brown.
Fantastic lecture. Whether Pickering was right and hypertension is a complex morass of lots of small things, or a very large number of rare discrete things, I suppose we won't know yet for a long time. But actually, that's not really my question. My question is how difficult it is to separate salt and calories in the obese patient. And Professor Faruqi and Professor O'Reilly, who you referred to, really one of the main messages from their work has been the importance of appetite rather than what happens to the calories after it's eaten as a cause. And an interesting question is, because a fat person can't really eat lots of food without eating lots of salt, is to what extent salt appetite might be playing a role in driving the increased intake of salt, and whether the obesity is almost a bystander, it's the salt intake which drives the hypertension. Have you any thoughts on that?
Yeah, this is an interesting question, and that's why we went to animal experiments. In the animal experiments, I didn't discuss it much. We kept the sodium intake exactly constant, and we only supplemented the diet with cooked beef fat. The dogs like that very much, and so the sodium intake was kept exactly constant, showing the increased caloric intake could raise the blood pressure independent of sodium. One interesting finding that we found in these animal experiments, as well as in human studies, is that obese patients are not that salt sensitive early on, prior to the development of renal injury. So that in the dog model, for example, if we change the salt intake up and down, it doesn't have much effect, at least in the short term, in terms of causing changes in blood pressure. And the same is true in obese patients when they're young. There's one study that refutes that, and that's Rocchini's study that was published in the New England Journal of Medicine a long time ago. But most of the studies show that prior to the development of renal injury, they're not very salt sensitive. So I think it's a good question. Salt certainly could play a role in many of the patients, but there is a caloric effect independent of salt as well, as shown in the dog studies and animal studies where we controlled that.
Well, John, I think that George will be looking down with approval at your presentation, and he will also agree that there is life in that dog yet in terms of a research career. And we are delighted that you came and honored us with your talk, and it's great.
Thank you very much.
Thank you very much indeed.